now we're starting to find out that if we give people immunotherapy concurrently with radiation therapy, that we're not only helping the radiation therapy work better, but survival rates seem to be better as well. So we've got a clinical trial going on that's in collaboration with other major cancer institutions in the country.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Joel Mayerson. Joel is an orthopedic oncologist. He's the director of the James Sarcoma Program and a world-class sarcoma surgeon. The James Sarcoma Program is one of the largest and best in the country, and Joel and his team of experts take a multidisciplinary approach in treating patients that values collaboration and innovative surgical and post-surgical therapies that result in better outcomes for patients. Joel will give us an overview on sarcomas and some of the new procedures and innovative research going on at the James. Welcome back to the podcast.
Thanks, Steve. Great to be here.
So let's start with a quick reminder, a quick review on what exactly is a sarcoma, the different types, and maybe some of the symptoms and current treatments.
Sure. Sarcoma is a type of cancer that starts in the tissues in your arms and your legs and your pelvis. So if you think of muscle, fat, blood vessels, bone, all of those organs, the type of tissue is called mesenchymal tissue, and anything that formed in that area can form a sarcoma. So if something forms in fat, it's called a liposarcoma because of fat. If something forms in bone, it's called an osteosarcoma because it forms in bone.
So bones are considered tissue, so that's why they're sarcomas.
Correct.
Okay, so I guess that makes sense that bones are formed out of tissue, but just denser.
They have calcium in them, which makes them hard, and so the collagen part is actually the tissue part, and then they have a structure of that collagen and of the calcium that allows them to be the structural component, allow us to ambulate and our muscles to work. And so there are two types of sarcoma in general. There's a soft tissue sarcoma. Those form in the soft tissues in our arms and legs, so our muscle and the fat and our blood vessels. And bone sarcomas, those form inside our bones. The symptoms of a soft tissue sarcoma are different than of a bone sarcoma. And so for a soft tissue sarcoma, it's usually a painless growing mass that is either superficial or under the skin or deep inside your muscle. So if something is getting bigger, doesn't really hurt, and just keeps on growing, that's a warning sign. Please see someone, go see your doctor, and get the appropriate help. Bone sarcomas are a little bit different. Just as the architecture we talked about that makes the calcium there to strengthen our bone, a bone sarcoma will destroy that calcium architecture, make the bone weaker, and so it will cause pain. When we walk and you get up and you put weight on it, that hurts. They too will break out of the bone and get a soft tissue mass in time, but usually the first symptoms are pain that's just at rest. And so most of us, if we do something too much, we get weekend warrior type pain, especially as you get older. That type of pain will go away in a couple days if you rest. Bone tumor pain will just be this dull, constant ache that just never goes away and eventually gets worse as the bone gets weaker.
It sounds like with both soft tissue and bone sarcomas that the symptoms could be confused with other things. So it's important to see your primary care physicians, and hopefully your primary care physician is well trained to recognize signs.
Absolutely.
That they're your intro to you.
Absolutely. And that's really one of our jobs as well, is to educate the medical community on the signs and symptoms. Because these are rare, sometimes education is a challenge or even for primary care docs. And so those are the reasons why we want to have awareness and have public education just like this, so people can learn about these things, so when something's not right with their body, they get the appropriate check.
So when a primary care physician suspects something out of the ordinary, would a scan be the first way they would detect something?
Yeah, typically for a bone problem, they would get an X-ray.
Yeah.
And then for a soft tissue problem, they would get an MRI, and then they would find something abnormal and then refer to our team.
And then when they're referred to you, I know you are a great surgeon, so surgery is one of the key elements of treatment. But what's the bigger picture, what the basic treatments are?
Yeah, sarcoma really is a multidisciplinary team system that allows us to care for patients. It involves surgeons, both from my orthopedic standpoint, as in my specialty. It also involves general surgeons that specialize in the abdomen and the pelvis. Those are surgical oncologists. We have medical oncologists that give chemotherapy and immunotherapy. We have radiation oncologists that give radiation therapy. And then we have doctors that help us do our job, such as a radiologist who reads those imaging tests, a pathologist who gives us the correct diagnosis so we can do the correct treatment. And then we have surgeons, other surgeons who help us in the OR who like plastic surgeons who reconstruct the defects that we create by removing the cancer and help make people functional and fill in the area to make it look as normal and function as normal as we possibly can.
Yes, because I don't know if this is going to be correct what I'm about to say, that bone sarcomas might be more invasive because you're removing parts of bones and joints and replacing them.
Yeah, exactly. So the structural stability of the limb is affected. And when we take it out, we have to restabilize that in order to make the limb functional.
But you've talked about this in the past. You're doing some incredible things where you're replacing sections of legs, knees, hips, shoulders. Really big, important joints and body parts.
Absolutely. We can replace almost any bone today. In the past, we did them with sort of an erector set, like segmental pieces, where we could replace an entire femur or replace most of a tibia or an entire humerus, and we could get the correct sizes by having smaller pieces and put them together, such as with an erector set type prosthesis. And then they will fit on top of a modified joint replacement, similar to what people get as they get arthritis when they get older, but instead of just a cap on the end of the bones, it actually is a segmental metal piece that replaces the bone that was removed. But today we actually have new systems where we're using 3D printers to replace entire bones that can be customized that are not off the shelf. So if someone's pelvis needs removed in certain areas, we can take the CT scan and the MRI scan, get an exact size piece, and then figure out where we can find anchoring spots in the bone that's left, and use 3D printing, and then use navigation tools, which are computers that are aligned with the imaging to have the precise cuts, so we know exactly where we want to take it out to get the cancer removed, and so that the customized piece fits exactly what was removed, so we can make people more functional.
Wow, that's amazing. What is the material that the 3D printer makes these bone replacements out of?
You can make it out of anything, but most of the time it's either titanium or cobalt chrome.
You can mold titanium?
With a 3D printer, absolutely.
I would think, I'm picturing to mold titanium, you have to heat it up till it's molten.
But
so it's a different way.
It's a powder,
okay.
And so the powder is sort of like a spray, and then they use heat, and that's a little bit beyond my engineering capacity. But yes.
But you've given me a mental picture of that, and that's amazing. And it's obviously a sterile piece of molded titanium that will fit perfectly into that specific person's body. And how recent is this that you've been doing this?
So we've been doing these over the past, probably for 3D printing, 5 to 7 years. And it's gotten better and better as the technology with 3D printers has gotten better. And now we can combine that with navigation. We've also done some cutting edge research and there's one orthopedic oncology company in the world, and that company has sort of helped lead the development of cutting guides. And so we use 3D printed cutting guides that exactly measure the exact area where you cut the bone above and below the tumor that we can get with engineers on a surgical planning call, and that we can get very close and make multi-angled cuts. And then what's really great, if we have in the middle of the bone where we're just taking out a segment, the top and the bottom, we don't have to replace the joint, we can actually take a cadaver bone, someone who's donated their bone to a bone transplant, and cut that that cadaver bone exactly the same size we cut out with an exact replica of those cutting guides, and put it in, and it matches perfectly size, all the angles we want to put for stability. And it's much, much easier and saves us an hour in the operating room, which decreases infection rates too.
So help me picture this cutting guide. Is it a mark on the person, like the computer?
And so they're actually made out of plastic,
Okay.
that are done with a 3D printer.
Like
the
a
same way,
cast that you put over?
and so when we open up the incision, and they're put on the top of the bone and the bottom of the bone, and then we use
And that's where you cut.
And that's exactly where we cut. So it gives you a cutting guide to place your bone saw. So you get an exact cut that we can get within a millimeter or two of exactly where we want to cut.
So in the past, you had to sort of measure or use your eye, and you were
A combination
close,
of-
but now you're exact.
Exactly.
Wow, it's amazing. You would think surgery is as good as it's going to get, but it's always getting better, and it's amazing the advances in surgery.
Yeah.
So these are all sort of the elements of a multidisciplinary sarcoma program, and like give me a sense of how many people. I know some people are overlap in many departments, but how big is your
Yeah, so we
team?
have about 19 physicians here at the James that work with our sarcoma team. And then we also have, beyond that, we have physical therapists, and we have nurses, we have advanced practice providers. All of our team, one of the great things, we're just going to open a new sarcoma clinic at the James. Actually, a week from today is the ribbon cutting ceremony over in the James outpatient West Campus Center.
Later today?
Next Friday.
Okay, next
Friday is the ribbon cutting ceremony, and then our first patients will get seen on the Monday after that, so it'll be July 1st. And that clinic is going to have a physical therapy clinic that is right next door to us. And so what that's going to be fantastic for is we're starting a prehabilitation program. And so we're going to be able, when we're ready to do these big surgeries on patients while they're getting chemotherapy, they will also be able to get nutrition therapy. They will be able to get physical therapy to strengthen the muscles they need to have a better recovery, and we'll be able to get them really optimized so they can take on the recovery after the surgery in the best way possible.
Is that a new trend, more chemo or immunotherapy before surgery?
Actually, osteosarcoma is the cancer where preoperative chemotherapy actually started from.
Oh, okay. So I'm hearing more of that, and
it's
you started
morphing into other
yeah.
forms of cancer. And really, for us, the survival rate in the 1970s wasn't very good for osteosarcoma, and so the orthopedic surgeon asked, "Can you give them some chemotherapy to stall the tumor so we have time to make a custom metal implant to put it in?" Beforehand, because back before we had chemotherapy, the survival wasn't good and people got amputations. They gave the chemotherapy, the metal device had time to be made, the surgery was done, and they realized the survival rate improved from 20% at that time to 50%. And that was the start of sort of neoadjuvant chemotherapy in cancer.
And now you're getting more and more chemotherapy and immunotherapy options.
Exactly.
Would you ever do radiation before surgery?
And so for soft tissue sarcomas, the standard in many soft tissue sarcomas is to get radiation therapy preoperatively. We're now combining immunotherapy with radiation therapy before we do the surgery, so hopefully we can kill what we call the reactive zone right outside the tumor. And about 20 years ago, we realized there's a study that was done that showed that even if a sarcoma was sitting on a critical important structure like a nerve or major blood vessel, if we gave them radiation therapy before we took it out, the microscopic tumors that sat right at the edge of the board or the outside would be killed by that radiation therapy, and we could peel it off the structure and do a limb sparing operation instead of an amputation without adversely affecting patient's outcome.
Wow, so within your own career, the changes are pretty amazing.
It's been drastic, yeah.
And you did mention physical therapy, and because you're replacing major parts, physical therapists are a really key part of the team.
They absolutely are. They really make or break these big reconstructions, and our specific James physical therapy team has a lot of experience dealing with how to prehab and how to help the patients recover for rare operations that most physical therapists in the community don't really see in their career.
So I guess the point is that to have a large multidisciplinary sarcoma center and now clinic is what separates you from, smaller hospitals that just don't have the scope.
Absolutely, and it really is their entire continuum of care. And so from the moment they hit our door, they're taken care of by multiple physicians every step of the way. And that starts from the radiologist partnering with the surgeons to get a correct diagnosis plan, to get a biopsy done, to then the pathologists who are specialists to make sure they get a correct diagnosis. And so we actually did a study here that for people that had biopsy outside our institution here in the community, the diagnosis was actually changed about 25% of the time when our pathologists, the experts, looked at it.
Meaning the initial diagnosis missed something.
Correct. And so that makes a huge difference in care because we want to
treat something if you don't know exactly what it is.
Exactly. And so that continuum happens with a diagnosis. And then we have a tumor board where before we start everyone's treatment, all the physicians that we've talked about from all those specialties, we see are there any clinical trials that someone is available, and those clinical trials may give someone access to a new drug that's not available in the community that's being researched, and so they'll get standard care plus a new drug that may give them better survival. And so that's part of what we're studying. Those studies usually don't happen in the community as well. Then we get to do some of the cutting edge surgical things that we've been discussing, and then our physical therapists get to take over afterwards. We have plastic surgeons who do major reconstruction for us that generally people in the community don't do. So it's really every step of the way in a continuum of patient's care.
All right, that was a great overview of the James Sarcoma Center and where you are today. We're going to take a quick break and come back and talk about what's next.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back talking about the James Sarcoma Program. So talk about what's new, what's research, treatment, and what's going on.
Yeah, we have really a lot going on that's new as science advances. The first thing that sort of is new is immunotherapy. Immunotherapy has been huge and really started in some other forms of cancer, but now we're starting to find out that if we give people immunotherapy concurrently with radiation therapy, that we're not only helping the radiation therapy work better, but survival rates seem to be better as well. So we've got a clinical trial going on that's in collaboration with other major cancer institutions in the country, that the preliminary results have been excellent, and we think they're going to become the new state-of-the-art care.
Is this for a certain type of sarcoma or location on the body, or just any sarcoma?
Right now, there are a couple different subtypes of sarcoma that we're studying, and we're trying to narrow it because there are about 70 different subtypes of sarcoma.
Right. Yeah.
And so we know that some of them may have predisposition to the immunotherapy, and so we're doing it in a couple subtypes, and then hopefully that'll translate into further.
So that's what perhaps this clinical trial is trying to determine, which types of sarcomas respond best to which types
Correct.
of immunotherapies,
Correct.
which you don't know until you try.
Exactly.
Okay.
The next thing is in radiation oncology, the James got the first proton center here in central Ohio. And so we're trying to see if there are different tumors that might be amenable to proton therapy. And proton therapy, compared to standard radiation therapy, allows you to cone the beam down to a much smaller area, and so it doesn't damage tissue. And so our radiation oncologists are trying to come up with new ways to utilize this technology to spare normal tissue. In orthopedics, we're collaborating with our veterinary medicine colleagues, and we actually are working on a way to improve surgical margins. Surgical margins are the normal cuff of tissue around the cancer that has microscopic disease in it. And so normally when we take out a tumor, we say the margins are negative. That means there's a cuff of normal tissue over the tumor that encases that microscopic disease. The way the pathologists figure that out today is they put ink on the specimen after we take it out. They prepare it, and then they slice it like a loaf of bread. They measure the distance between the ink and the tumor, and as long as there's normal tissue between that, we call that a negative margin. Sometimes in the operating room as surgeons, it's very difficult to tell if we have normal tissue because of the scarring from the radiation therapy, or the muscle will contract. And so in the veterinary world, dogs get sarcomas as well.
Right.
And so the veterinarians found a device called optical coherence tomography, which is similar to ultrasound. And it's a probe that you can place on top of the tumor, and it can tell the difference between normal muscle, normal fat, and tumor. It can also tell the depth of that tissue, and so we can tell if we have a 2 millimeter margin or a 3 millimeter margin.
So in real time, while you're operating, you can get clear, clean margins and know that you've gotten all the cancer?
That's our goal.
Okay,
We're not there yet.
But okay.
And so where we've gotten so far is they've taken that from the dogs, and we started a trial here at the James of 20 patients, and we took a small area and put the probe over it, and we assessed the margins with the probe. We marked off that area, took the specimen the same way we normally would, and had the pathologist evaluate the same way we did, and we found that we got margins very close to what the pathologist would be able to say today. And so the next challenge is sarcomas are often very large. I've taken out sarcomas 30 centimeters, so that's 30 centimeters is 12 inches.
Wow.
And so you have to be able to take that probe and put it over a very large surface area, and you have to do it in real time because the patient can't stay under anesthesia for 10 hours while we're trying to do this.
Oh, you can't take it out, send it to the pathology lab, have them analyze it, send it back, because that's just a delay. That's
It's
not
too long and
Yeah.
not functionally suitable to do currently.
And the goal is to make sure you get all the cancer cells, but not too much more normal tissue.
Correct.
As little normal tissue as
Because
possible.
if we take out some extra normal tissue, that's function gone.
Yeah.
And then nerves and blood vessels are nearby, and if we take those out, then sometimes the leg can't be salvaged as well. And so we actually after taking that pilot data, we got that small study was funded by Steps for Sarcoma. That's our philanthropy event that we have here to support our sarcoma program, and we applied to the university. It's called a Presidential Accelerator Grant that the university president here at Ohio State gives to collaborative researchers. And so the veterinarian and I and a professor in computer science and biomedical engineering are using AI, or artificial intelligence, that he's hopefully going to be able to, what he's doing now is to write some code to take and see if we can train a computer to assess a much larger surface area, and then hopefully the goal, we would be able to do that in a much larger area. And so he's starting to do that in the dogs, and as he gets the code and we get it in the dogs correct, then hopefully we're going to be able to do the next study in humans and try to get large surface areas of entire tumors. And that, hopefully, our goal is what you said. We would be able to know what the margins are before the patient leaves.
Wow, so it sounds like 20 or 30 years ago, surgeons had to err on the side of caution and take a lot more out to be sure they got all the cancer, and that led to more problems for people with quality of life. And now you're refining it little bit by little bit, and you're getting closer and closer to taking out the minimum amount of tissue and making that person's recovery and quality of life better.
Exactly. And so now we're getting to the point where people's function is amazingly close to what it was before their surgery, even though we're taking out a significant amount of healthy tissue.
Or a bone.
Correct.
Yeah.
We also, the molecular testing for pathology is changing the horizon, because as we get new markers and new fusion proteins that the pathologists are able to tell us, and new diagnoses, they can then search banks of medicine that work against potentially that genetic defect, and they can have what's called targeted chemotherapy to try to help treat things in multi-layers that's safer for the patient because it's not traditional chemotherapy that kills all cells. It's targeted just at that cancer cell.
And they've been able to target those mutations or cancer cells exactly their genetic makeup.
Exactly. So we have a new project that's really building the international scope of our program in sarcoma in a partnership with actually the government of Ecuador. And so I have a patient who came to us from Ecuador. She had an osteosarcoma, and the cutting guides that we've been discussing were necessary to take out her tumor and to reconstruct her in the best way possible. Her father is an international businessman. They've been very grateful and realized that sarcoma care, like we have here in the United States and at the James, is not available in Ecuador. And so he helped us get in contact with SOLCA, which is the National Cancer Institute equivalent of Ecuador, and partner with them to try to build a sarcoma program so people in Ecuador can get appropriate sarcoma care.
So your expertise is going over there to train them to treat people in Ecuador.
Exactly, and so we had an Ecuadorian surgeon who they've chosen to lead their sarcoma program, came to the James and spent a year with us in our program last year, and learned all about the techniques and the advances we've done. He's subsequently gone back to Ecuador and with the plan to bring more physicians up here. And then we have a tumor board with their physicians, so we help them.
You meet on
a regular basis. Wow. When they have patients who need our help, we can actually help guide them. And now he knows what we can do, and that's really helped their care. We've taught him some surgical techniques. He's actually a general surgical oncologist. And so as we get more and more physicians trained, the goal is they're going to have care in their country for people who may not be able to afford to come here to America.
What's that like to be able to impact lives in a country thousands of miles away that wouldn't otherwise be able to get this kind of life-saving care?
Yeah, it's really one of the most satisfying things I've done in my career, just to get started. I know it's going to be for the long haul because it's going to take them a while as a country with less resources than we have, but to be able to know that I'm impacting patients already several thousand miles away from here in another country when those resources would not have been available without our help and my team's help. And they're really benefiting from our entire team. It's just immensely satisfying.
So, because I know education and awareness are very important to you, as you just talked about internationally, and here in Ohio you have a new sort of education initiative.
Absolutely. The Hank's Law is a law that was passed by the state of Ohio that recognized Sarcoma Awareness Month. It was passed in 2023, and it took what was already available, Sarcoma Awareness Month, made it a law in Ohio, and now we've had different, City Hall is actually this year in Columbus, and Sarcoma Awareness Month in July is going to be lit up in yellow, which is the color for sarcoma, and there are 10 other sites throughout the state that are going to be lit up. This is providing awareness as hopefully people look up into the sky and say, why is City Hall yellow? There will be in the dispatch, hopefully, or on television, people saying that's for sarcoma. They'll say, what is a sarcoma? And hopefully they'll have a conversation with a physician or someone that they'll learn the signs and symptoms. And hopefully if we can just save one person or more, we've made a difference.
So early diagnosis is the goal because that leads to better results.
Absolutely.
So who was Hank that this law is named after?
Hank was actually a dog.
Okay.
He had an osteosarcoma. Their dogs get osteosarcoma, and the behavior of osteosarcoma.
Because you see a dog with a missing leg, and
correct.
That's usually right.
And our veterinary school here sees a lot of them. They're a national leader in the care of dogs with cancer. And so a woman in Lancaster, Ohio, had a dog who had needed a very big operation, and I helped her family get to the right veterinary people and helped the veterinary people get to the right operation. She got her surgery. Hank got his surgery done. He survived longer than he would have in a more functional way. Amy was very grateful. and she started advocating and worked with leaders in the James and myself to advocate to our state legislators of the importance of education and advocacy for this rare cancer, and it led to the passage of Hank's Law.
Wow. So advocacy works, and raising money for research works. And you mentioned Steps for Sarcoma funding a clinical trial. Tell us a little bit more about the upcoming Steps for Sarcoma and what you've accomplished over the years.
Yeah, Steps for Sarcoma is our homegrown philanthropy effort. That I call it our mini Pelotonia.
Okay.
That we have a walk. It's a 1 mile walk every year. We started, this is our 16th year. Back in 2009 we started. It was in the park down the street from me. We had about 200.
From your house?
From my house,
okay.
Yeah. We had about
Is that so you could get there easier?
Exactly.
Okay.
We had about 200 people, and we raised about $7,000 that year. But we helped with awareness. We've grown the event year after year after year. Last year we had about 1,500 people.
Wow.
And we raised $190,000.
Wow.
Making it one of the largest sarcoma events in the United States for rare cancer. And we take that money and we provide pilot grants for our sarcoma researchers here at the James, at our College of Veterinary Medicine and Nationwide Children's Hospital, all part of our Ohio State Comprehensive Cancer Center. And those pilot projects are $30,000 to $40,000 worth of research to get data so that we can apply for larger grants to larger organizations.
Right.
or the governmental funding agencies that hopefully will lead to bigger discoveries. And that's what's really missing in research, because for rare diseases, getting that pilot money to start those projects is really difficult to get. Normally, and just as in everything else in life, people want to spend their money on something that's going to be the biggest bang for their buck to help people. And so more common cancers are able to outcompete us to get that money for those starter projects. And so this was our way that we could start that funding to get researchers started so that they could apply for bigger grants.
So when is Steps for Sarcoma this year?
It's September 21st at Chemical Abstract Salon, right across the street from the Buckeyes practice facility.
Oh, they have that like green rubber track that goes
Exactly,
down.
exactly.
Nice
That's
soft,
exactly
yeah.
where it's at. So it's a 1 mile walk. I would encourage everyone to come and join us. It's fun, and we get probably one of the largest collections of sarcoma survivors in the
That's
country.
what I was going to ask. That they probably come from pretty far away.
They do, for hours away. And that's one of the things that's hugely satisfying for me. I get to see a large group of people that would not be here were it not the help from our team. And so it puts a big smile on my face as the picture gets bigger and bigger every year.
So you're still a young guy and have a long way to go in your career, but even in, 20, 25 years, the changes have been amazing, and the next 25 years are going to be even as much or more so.
I sure hope so. We've talked about a lot of the surgical advances that we're undergoing. As technology increases, we're able to take advantage of that. And so we can leverage technology to do less invasive surgery. Our reconstructions hopefully are going to be more durable to allow people to be functional for longer and in better ways. Our rehab techniques are getting better as we get more specialized care. Our diagnostic capabilities using molecular technology is getting better, so we can diagnose things the correct way, so we can use targeted therapies that are more directed at their cancer. And so really the entire continuum of our team and every aspect of cancer care is improving, and that's really why it's so important to have a sarcoma team to take care of these rare cancers, that patients get access to all these individual advances uniquely in one area, but as they get in one area, it builds for the rest of them to improve cancer care in this area.
Well, thank you for your leadership, and here at the James and beyond in Ecuador, and thanks for filling us in and everything you're doing.
Thanks for having me, Steve.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.